This is the chain of clinics. It's known as the Right Bite Sleep and TMJ Pain Care. We started off with Bangalore and Delhi. We are now in Mumbai and Calcutta as well. We've opened our fifth center in Jeddah in Saudi Arabia, and we are opening pretty soon, this year itself, hopefully, in Dubai. The reason why we are opening so many centers is because there are not many people who do this. All our patients are just going around in circles with headaches and migraines, visiting ENTs and neurologists, just being treated with medicines and injections, Botox and splints, night guards. But none of these are taking care of the cause of the problem. In order to be a good neuromuscular dentist, you need to be a good diagnostician. And this is what the Right Bite aims at doing, and which is what ICCMO as an organization tries to create the awareness among all the dentists. None of what we do is possible without this amazing team that we have, and we are constantly growing. Almost 2 or 3 staff every day, every month we are increasing because there are so many patients out there, and that is the potential of neuromuscular dentistry. When people say dentistry is too saturated, I beg to differ. There are so many specialties out there that we need to explore, but that is only going to happen if you open up your mind a little more. ICCMO is known as the International College of Craniomandibular Orthopedics. It's the only organization for neuromuscular dentistry. We are the proponents of functional and physiological occlusion with regard to TMD or sleep apnea. And back in 2015, we started, ICCMO started its 8th section, known as ICCMO India section. We are currently 41 members, and it's been pretty tough in the beginning, but now people are getting to understand, and we're going from strength to strength. And there's a lot of potential to grow much stronger. We got 500,000 dentists in India. I'm sure we could achieve a strength of 150 to 200 easily. That's me. I'm currently the secretary of ICCMO. On the right is Dr. Ronkin, who is the president of ICCMO International. And in the middle is the dean of the college, Dr. Norm Thomas. He was also my mentor for my PhD thesis and my mastership. This is me taking over as secretary in Moscow in 2019. And that is the Board of Regents. They're all 90% of them are going to be there in Goa at the conference. So it's going to be an amazing show. So ICCMO has a ladder that everyone tries to utilize to their benefits. You start with attending 300 hours of continuing education, which you can attain from anywhere in the world. We provided in India. We are tying up with various universities. So I think that's where the conference is where you start off with. And then once you think, if you think that this is your cup of tea, then come to the course. Once you do the course, then you provide 3 cases that would, after you pass an exam, that would give you your fellowship. And then you write an exam for your mastership, and you present a thesis under a mentor. And if you get through the Viva, you get your mastership as well. Back in 2015, I got my fellowship and mastership, which, by the way, I got it together. I'm the only one who has done that so far. So I'm kind of proud of that. Sorry if I'm not sounding humble. And this is the Congress that we're talking about. There's going to be 40 speakers from all over the world, spread across 3 days. We have an entire day for workshops, pre-conference. There are 5 workshops that are going to be there. Various companies are launching during the Congress. There are going to be parties because it's me, I'm conducting it. So there are going to be parties. So it's going to be learn and enjoy. Okay, so it's on the white sandy beaches of the Lalit, and it's going to be an amazing thing to be at. The magic of energy. Is it really magic? I show this patient case to during all my presentations because it's an amazing case. Patient complained of trigeminal neuralgia. He was diagnosed with trigeminal neuralgia. Trigeminal neuralgia. He couldn't talk. He couldn't tell his name. In about 2 weeks of wearing the orthotic, that's how he is. So if he really had trigeminal neuralgia, he would not have gotten better. So this is why diagnosis forms an important part. Did he, to start with, really have trigeminal neuralgia? Or was it just a differential diagnosis with TMD? This patient came to us all the way from Europe, Austria to be precise. She had a filling done on one of her lower teeth. And after that, every time she tries to stand erect, her whole body jerks. All we did was tense her, put the bite registration material, ask her to walk around with it. And in 10 minutes, she's as straight as she can be. Just one of those cases that, we normally treat. So various misdiagnosed cases, cluster headaches, musculoskeletal pain syndrome, tension migraine, fibromyositis, MPDS. These are all vague and complicated diagnostic terms. I've even heard doctors say idiopathic fibromyalgia. Well, it's idiopathic because they can't find the cause of the problem. Because the doctor who did that, who came up with that term, is an idiot. Sorry, take that back. But that is the fact. If you're not, this is how I see it as, if you're not able to diagnose, don't treat, don't touch, because you're going to create more harm to the patient. These are all neuromuscular disorders that have gone undiagnosed, most of them due to a simple bad diet. We can stop this and help these patients by incorporating the principles of muscle physiology and neuromuscular dentistry and functional occlusion in everything that we dentists do, everything. Like I said, from something as simple as a single tooth filling to full mouth rehab. TMJ. It's not temporal, it's temporomandibular joint, by the way. It's also teeth, muscle, and joint. Online, too much junk. This is why people call TMJ very complicated. It's not complicated if you understand muscle physiology. It is not complicated. You do not have to treat TMD with injections or splints or deprogrammers. If you understand muscle physiology, you can treat them precisely with reprogrammers. And online, there's too much junk. Dr. Bernard Jankelson, all the way back in the 70s, came up with this whole concept of muscle physiology. He's known as the father of neuromuscular dentistry. What his motto was, if it's being measured, it's a fact. If it's not, it's just an opinion. And this is how we, as dentists, have been trained in dental school with arbitrary points. Well, back then, there was no other go other than following arbitrary points. The sad part is, even with the advent of technology, even with the advent of muscle physiology and understanding how it's important in creating TMD and finding the right occlusion, we still follow textbooks that believe in arbitrary points. We are still taught the same things. And which is why dentists still say TMD is biopsychosocial. No, it isn't. They get psychosocial because they're not able to get treatment. It's the other way around, again, from our experience. And people always question me, what's the proof? Well, there are like thousands of research papers out there. We're just not looking for it. That's the problem. We are just kind of lazy and laid back. Okay, I know what I am, and that's it. That's because we continue to see ourselves as tooth doctors. You have to relearn your first year anatomy, physiology. We always crib during our first year. Why were we taught about the muscles of the neck? I used to do that. I used to say that. But now I know why. Because every change in jaw position, there's a change in your cervical position. And during the conference, there are 3 or 4 lectures just for posturology and how the jaw position is going to help improve the whole body position. So the aim of the NMD is to keep the stomatognathic system happy. And the stomatognathic system consists of muscles, joints, airway, and teeth. No matter how malpositioned the teeth are, the muscles will struggle to create a centric occlusion. And this is the point. If you have a malocclusion, which, by the way, there's research that shows 92% of the whole population has a malocclusion. So they are all patients who have a tendency to form TMD. So we can intercept that with doing the right dental work. If the teeth are this way, the jaw will move that way. If the teeth are this way, the jaw will move that way. So, and that's going to create an imbalance in the muscle system. And that's how TMD and other facial pain disorders are created. Just as a simple example, I try to make things as simple as possible. Look at this guy. You can see one bicep is really, much more hypertrophic than the other. Why do you think that? He might be using that arm more. Let's use the same concept in the face. This girl, I'm sure, on the left side of her jaw would have a missing tooth or some sort of malocclusion, which she's not comfortable with. So what would a normal human being do? They would use the other side. Slowly but surely, that muscle would start hypertrophying and the jaw would also move that way. Those muscles would become tight. They start to struggle because they're hypertonic. And that's how they end up with temporal headaches, migraines, neck aches, shoulder aches, and it's a descending thing. It's like a domino effect. It starts here and then it goes down, down, down. Because that's how the postural chain is. So what does neuromuscular therapy involve? To reduce the malocclusion that causes the noxious stimuli. So we have to relax those muscles, thereby relaxing those hypertonic muscles. So does NMD have anything to do with occlusion? Of course. It's all about physiological occlusion. We have been taught about centric occlusion, but we should be aware that centric occlusion and MIP is achieved only during swallowing, never else, not even while during bruxing. So all we have to do is understand that this is the main crux of neuromuscular dentistry. It's not the teeth that decide where the occlusion is. Yes, it is the teeth that decide where the occlusion is, but it's the muscles that control the jaw position that holds the occlusion in place. So if we get the jaw to the right place, for that we need to get the muscles in the right place and then get the teeth to the right place. That's how we need to start treating. First get the muscles and the jaw in the right place and then the teeth. I'm not going into the anatomy, but all I have to talk about is the disc. What is the disc? The disc is literally an extension of the superior head of the lateral pterygoid muscle. We have learned this in our first year. So if, like that girl you saw previously, if she's chewing only on one side, if she's clenching and bruxing just on that side, or on a whole, the lateral pterygoid is the first muscle that, gets hypertrophy. It shortens. Once it shortens, the disc is connected to that and it comes out. That's how we hear it. And it's been proven that 90% of all IDD, internal derangement, is myogenous, muscle origin. So what is the clicking? So any occlusal prematurity would lead to a noxious signal that would then be engrammed in the head, in the brain, which would then cause hyperactivity, leading to RAS activation, which is a pain spasm cycle, which would then lead to the muscle shortening. And when the muscle shortens, it pulls the disc out. When it pulls the disc out, we hear the click because it doesn't reduce anymore. It reduces after some time. So when that process of reducing causes that click to happen. If you do not do anything about that occlusion, the muscle continues to get hypertrophy, it becomes more shorter, and the disc gets permanently pulled forward, which then leads to without reduction. So if it goes to without reduction, then what happens? The mouth opening reduces, and we try to give all sort of splints and night guards, stop the clenching. But no, you're not taking care of the cause of the problem, which I'll talk about during 2 slides in sleep that I'm going to get to. So any patient that comes to me with IDD without reduction, when you give them an orthotic, I don't call them splints anymore. They're known as orthotics. I'll explain why later. So when you give them an orthotic, after a couple of weeks, the patient comes back complaining, "Doc, what treatment is going wrong? I'm hearing a click." So the click is a good thing because the disc from totally outside is now, the muscle has relaxed, so the disc is now able to go back into place. And then you might have to change the orthotic because it has to go back fully into place. And that's the physiology of clicking. It's as simple as that. It's not complicated. It's very simple. You just have to open your mind. Signs, headaches, migraine. Most of the migraine that's diagnosed in India is not migraine. It's basically TMD. How is migraine, for example, diagnosed in not just India, all over the world, actually? They'd have headaches, morning headaches. They go to ENT, they get prescribed with medicines, and it doesn't go away. You try another set of medicines, still doesn't go away. You have migraine. No, that's not how you diagnose migraine. So this is the problem. That would have been a perfect example of TMD-related headache. Intraoral signs, crowding, excessive wear, lingual inclination. See, if you go through this entire list, you might understand, you might get to feel that most of it is related to class 2 deep bite patients. And yes, that is the problem. It's a developmental issue. And neuromuscular disorders could be ascending and it could be descending. So as an example, for that girl, if the jaw has gone this way, the head will tilt to the opposite side. Why? It's a compensation. That's how the body functions. The body has a response mechanism till it causes a problem. Saturation point. When it crosses that saturation point, the problems come again. The head tilts, the shoulder on the opposite would droop, the hip would move to the other side, the arms would come forward, the feet would pronate, the hips would change position. So, and that's how patients also have backaches because the spine is now becoming scoliotic. They would go to a physiotherapist for their neck pain, shoulder pain, and lifelong they have to go to physiotherapy. The minute they stop physiotherapy, the pain comes back. Why? Because the cause of the problem is still not solved. So the cause could be here or on the other extreme, which is the foot, the plantar fascia. So we've helped patients with both intraoral orthotics as well as foot orthotics. So it's all about diagnosis. So the right bite protocol is something that me and the team have come up with our experience in this because there's no one else, to guide us. So I had to come up with my experience. It's a very exhaustive protocol. We teach the whole thing during the courses. There's a detailed, exhaustive questionnaire. There's radiology, palpations, rotations, intraoral, extraoral examinations, cranial nerve screening, heart rate voltage capnography we use for our science. There's postural examination. A sleep study is very, very important. We'll get to that. This is the questionnaire. It's actually a 10-page booklet. We've just taken 1 page of it just to show you. CBCT is, what we've been trained in is to take an MRI, but that MRI has to be 3D, real-time video with TMJ coils, because only then would you understand where exactly the disc is, whether it's anteriorly placed or posteriorly or medially or laterally. But guess what? There's just one in the whole of Southeast Asia. And that too, I think one of the coils has got spoiled. I think it's in Dharwad, but this is the problem, or Hubli. And so this is the problem. No one has it. So we have to be happy with the CBCT. I'm happy with the CBCT because we know what to look for. Arbitrary points. You can see a beaking. You can see. So what is beaking? Form follows function. What if you see a deepened notch on the mandible, low border of the mandible. That's also because of a masseter pull. So form follows function. Beaking is when the condyle becomes like a beak, more often than not as a result of the lateral pterygoid pulling on it because of the clenching. So you see this a lot in the clenchers and bruxers. This is what we look for with airway volumetry. There are a lot of CBCT machines out there, but they don't take their the airway volume software. So with this, you can see how there is the side cut of the face. You have the tongue, you have the palate, you see a small space. That space is not supposed to be there. It's just indicative of how the tongue is not placed on the palate at rest, which has to be. So this would indicate that the patient has low tongue tonicity or even a tongue tie, which would then push the tongue backwards because it's not where it's supposed to be. It's not up there. So it goes back. When it goes back, you can see there is pressure on the airway. It's all red there. You can see that area is 71 millimeters square. It's supposed to be at least 200 to 250 millimeters square. And this is how the airway is when the patient is awake and standing. Imagine what's going to happen when they go to sleep. That whole thing is going, the muscles get flaccid, it's going to go backwards, and the airway totally blocks. When that airway blocks, there's not enough air going in, and the body has to respond. The heart starts to beat differently. It goes into variable blood pressure levels. It goes to the heart rate changes. But more importantly, for us dentists, again, the body responds. It has to open up. It virtually tells the tongue, go forward. As it goes forward, the malocclusion causes the bruxing. So when we provide those night guards for clenchers and bruxers, we are again thinking like tooth doctors. We are just stopping the further deterioration of teeth. We are not stopping the clenching. The clenching is still happening. If the clenching still happens, there's going to be TMD. So you got to think. Something else that we look for. This is why we need to work along with an ENT. So if the tongue is not on the palate, which if it's a tongue tie, it's from birth. So if the tongue is not on the palate during the growth stage, then that palate is not going to expand. It's going to grow this way. So that's why they end up with a high arch palate. And what is connected to the palate? The nasal septum, both the bone and the cartilage. So if this goes up, the septum bends. If the septum bends, there's going to be resistance to airflow. If the resistance to airflow, the tissues, the living tissues, they inflame. When they inflame, then the patient cannot breathe through that nose. You can see how the turbinates are all inflamed in there. Cannot breathe through the nose, and then they start to mouth breathe. When they start to mouth breathe, the jaw goes even more back and blocking the airway even more and clenching even more. So it's a vicious cycle. So the number one relapse surgery, one of the top relapse surgeries in ENT is the septoplasty. Why? Because the ENT is not looking at the palate as the cause. So unless they expand, this is going to keep bending. So when it expands, the palate drops down, and we use various techniques, which I'll be talking about, to bring that palate down. Once it comes down, that would straighten up. So we work along with the ENT as an expansion, appliances, surgeries, along with the septoplasty. So, and this is what leads the patient to a runny nose, constant colds, allergies, asthma. So patients come telling us, oh, my asthma is gone, thank you. My allergies have gone, thank you. Because suddenly they're opened up. Well, here's the thing. We do not tell the patient we treat asthma. All we tell is we are treating your sleep issues, we are treating your TMD. If anything else goes away because of that, great. But we know that it goes away because that's physiology. And so what we do with diagnosis is we check for cervical rotations. If there's a restriction to one side, that means the C1, the cervical vertebrae has rotated to the right. muscle palpations, all those muscles we check, extraoral palpations, intraoral findings. We look for the bite, we look for abrasion, missing teeth, arch shape, tori, which we'll be looking at. Extraoral findings, we look at the symmetry. I have a couple of slides that show that. So as an example here, I would show this case to almost everyone because it's one of the first cases that I saw, and I just use the same thing for my slides. The first thing that comes into our mind here when we see this is macroglossia. I believe macroglossia, if it's not systemic, because of having drugs or some other systemic issues, it is just an optical illusion. If arches are small, the tongue would look big. Now, why do you think the arches are small here? Do you see missing premolars? Do you see bite with drop off? Why did that happen? It's an extraction orthodontic case. So when a patient comes to you for orthodontics and you see crowding or you see a malocclusion with bimax, the first thing you do is extract. We forget, once you extract and you pull back and you organize it, then you give a retention appliance. Why? Why are we giving the retention appliance? So that there is no more relapse. So at that point of time, again, we're thinking like dentists. Our 1 year, 2 year of hard work has to be maintained with that smile. So give them retention. Why do we give that retention? We should not be giving those retention appliances. I don't remember the last time we gave retention appliances. Why? Because we're taking care of the cause of the problem. When you pull back, the tongue is going even more back, and the body is telling the tongue, no, go forward, go forward. And the tongue keeps pushing. That's why you see the lateral scalloping on the tongue. As it pushes forward, the teeth move forward. So to hold that in place, so the whole reason is we didn't take care of the cause of the problem, which was a narrow arch to begin with. So expand. Now, even if you do extraction, expand at the end of it. It's okay, as long as you're expanding. And the abfractions. What are abfractions? Just as an example. It's wear and tear. It's not toothbrush abrasion. It's because of the constant bruxing. And that's the point where the enamel is the thinnest. That's where it goes. A lot of dentists do fillings on that, and the filling comes off, and you tell them you're brushing too much. No, it's because they're still bruxing. Frenum, it's part of the fascia that starts from the tongue all the way to the back of the head. So if the patient has a neck pain and a lingual frenum, it's interconnected because this is now tight. It's pulling the whole head forward. The minute you release, the head goes back and the patient themselves say, oh, I totally felt released. Exostosis and tori. What are tori? Tori is actually bone deposition to make sure that the bones they don't fracture from the stresses of the bruxing. Again, as an example, when you throw a ball, you exert like 50 to 70 Newton force. When you chew food, you exert around 150 to 200 Newton force. We measure these. Every patient, we measure these. Even when we do a sleep study, we use a GEMPRO unit to measure how much bruxing forces the muscle is measured with every bruxing force. So when they brux because of an airway distress, they clench at around 10 times, 20 times the number. I've seen up to levels of 1,200 microvolts of muscle pressure. Any bone would fracture at that level. To prevent that from happening, bone is deposited, and that's why you see the tori. Just surgically excising out is not good enough. Posture, we look at posture. Against the grid, you can see how the eye level has shifted to the right. You can see there's a right facial hypertrophy. You can see there's a shoulder droop because to compensate for that, the hip has shifted to the right. You can see how his arms are forward and how his left foot is pronated. Small things. We use a lot of sonography because it's all digital. We want to hear when the disc is coming out of position, if it's an early click or a late click. And there are equipments out there that we can start using. So any of the TMD systems can be caused by having the resting points by just off, fractions of millimeters. So instead of searching for the centric occlusion, which we ask all patients to do, go back. Go back when you shoot a bite. Go as back as you can. When you're pushing it back, you should understand the amount of stress you're pushing into the TMJ space. Dawson himself has come out and said, yep, it's not the most recruited position. It has to be a more physiologic position. So how do we do that? By searching for the myocentric occlusion. So the aim is, instead of the habitual occlusion, where muscles are used to, and that's what's causing the pressure in the TMJ and the muscles to be out of sync with each other, we need to relax those muscles using specific equipment, which I'll show you, that creates a myo trajectory. So what's habitual has to come downward and forward, generally, no thumb rule. Downward and forward for a myo trajectory. And on that myo trajectory, we shoot the bite. So we do addition NND and reduction NND. So if the golden vertical, so we measure the golden vertical by multiplying the width of the central incisor by 2.08. Once we get that number, we then, on the myo trajectory with that vertical dimension, we measure the bite. So TENS, there are several TENS units out there. I generally use the Myotronics J5 and the SDI Matrix ProTens. So unlike the freely available medical TENS units, so when you go to a physiotherapy center, what they would do is they would apply the TENS on that specific muscle. So only that single muscle would relax. No, that's not good enough for us. It has to be bilaterally simultaneous. Simultaneous, not even a fraction of a second apart. It has to be at exactly 1.44 seconds, 1.5 seconds apart, because that's how the actin and myosin fibers, gain their perfect resting length. And this is research again, science. It doesn't go to the muscle, it goes to the nerve. That's how we place the electrodes. So instead of the single muscle, all the muscles supplied by the facial, the trigeminal, and the spinal accessory, all the muscles, which is like 99% of the muscles of the head and neck area, they all relax. So again, we need to measure. We need to be sure whether doctors come telling, oh, I felt it, the muscles are relaxed. No, there's no way. There's no way that you can do that. You need to measure. So we use EMG. Surface electromyography is good enough. Because if this muscle is relaxed, because the TENS is antidromic, we know the other muscles are also relaxing. And there is research with using needle EMGs to prove that those are also relaxed. And once we find the muscles relaxed, we place a magnet on the lower incisors, and then we use the sensor array, which would then help in, we're using electromagnetism, find out where the jaw actually has to be. This is the precise way of doing this. We can also do all of this by just using the TENS unit. And this is what we teach at our course. You need to learn how to use the TENS unit to shoot that bite. It's ultimately important. So people say, how precise is this? If you use the K7 with all of this technology, you are 100% there. But if you're using just the TENS unit, you're still 70% better than the other dentists in your region or yourself who have been shooting bites using arbitrary points. Because you're still using the muscle, you're understanding muscle physiology to shoot that bite. And then based on that, we recognize the the myo trajectory, which is downward and forward, and we shoot a bite on that. We record that bite, we send it to the lab, and we create an anatomic orthotic. It's no longer a splint. So when we've been taught to give deprogrammers to all patients, wrong. Stop providing deprogrammers. Deprogrammers, just as the name suggests, is just a deprogrammer. It is temporary. Why were we giving deprogrammers, and why are we still being taught about it? It's because we haven't understood how to use technology, even though the technology is out there. We provide reprogrammers. So the TENS deprograms, we register the orthotic reprograms to where the jaw actually has to be. And That orthotic is worn the whole time. I've heard doctors tell the patients, remove it during chewing, remove it when you're going to a party, wear it only at night. No, you got to wear it the whole time, 24 hours. Even when you swallow, you're again changing the programming. The muscles get confused. It has to be there the whole time. And to get that proper bite, patient has to wear it long-term, 6 months at least, generally on average. I've seen patients in 3 months. I've seen patients suffering, struggling for 2 years to get that bite because they are really chronic cases. Every 2 months they come in and stop using 200 micron. I've seen articulating papers with my name on it, Sanjay, or whatever terms are out there. Start using 20 microns. The thinner, the better. Or even better, technology. T-scan or occlusions. I know T-scan is expensive, but if you have the money, that's the best thing. Or just have an occlusion. You know how I see it as? Every dentist should have at least the T-scans, or if you can't afford that, at least the occlusions in your dental office. Because they start measuring from 5 microns. The proprioception levels of the teeth of dental occlusion is around 5 to 8 microns, as thin as your hair. So if you're going to be using 200 microns, you're doing a huge disservice to that patient. You're assuming you're going to find all those smudge marks. You're assuming where to reduce. No, use equipment. You know where exactly how much force is being applied. Then we check for the EMGs again after 4 to 6 months. May need 1 or 2 depending on the severity. Now the patient can't wear it lifelong. We remove that orthotic and we have to maintain the jaw position by bringing the teeth into contact. Now we become dentists, tooth doctors. So you got to stabilize that jaw position by either prosthetic neuromuscular orthodontic, which is my favorite. So as long as you have teeth, no matter what the age, unlike the misconception out there, no matter what the age, get the teeth into contact by supraeruption and expansion, or an orthotic wear. So we use, there are a lot of smile designing programs out there. We can see how for this patient on the left, she came with 20 years of headaches and migraines. You can see how tired her face looks. And in just about 8 months' time, this is how she is, all with renewed energy and vigor and a better smile. So if the golden vertical is more than the current vertical dimension, we have to add, which is what we do with prosthodontics and orthodontics and orthotics. If the golden vertical is supposed to be lesser, for example, in an open bite, then we need to start reducing, not grind all the teeth. Using these equipments like T-scan is very useful for that. Find out the disclusion timing, find out which tooth is exerting more force, which muscle is using that, and reduce using not just grinding away teeth, very slight microns of enamel. It's a procedure that the inventor, Dr. Rob Gerson, who is going to do a workshop at the conference, by the way, he's coming in person. So you got to be there. So there's occlusions and there's T-scan that uses all of this. Oh, now my favorite subject, obstructive sleep apnea. So the patient wears the day orthotic, he's fine. What if we feel clenching? Okay, because of an airway problem. So even if you wear the orthotic at night, the jaw is going to drop back because there's nothing to hold it up there. The tongue is still going to drop back. So what do? We need to give them a sleep appliance that will keep the jaw forward. Again, not at some random arbitrary position that we have been taught. We need to understand what is causing the obstruction. There are several nasomaxillary constrictions that are possible, but in our area, it's the tongue. So how do we diagnose? We have a questionnaire and we do a sleep study. So the stop bank questionnaire is basically going through the patient, snoring, feeling tired during the day, waking up during the sleep, blood pressure variations, exertional dyspnea. But the gold standard is by doing polysomnograph, much easier using the watch pack. The PSG is for really, really serious patients, or using the GEMPRO BioBlocks. And this is what we look for. The AHI index 21. It's pretty huge because it is not sleeping for at least 10 minutes. What is the AHI? It's the apnea hypopnea index, which means that the patient is not able to breathe for more than 20 seconds with every apnea event. So if the patient has 21 AHI, that means for almost 10 minutes, they're not breathing at all. I've seen patients with 80 and 100 AHI. They're like zombies. But more important for me is the number of desaturations, because every time there's a desaturation, the tongue has to come forward and there is a brox. Now, how do we measure that? Using the GEMPRO. You can see over here in this patient, in this patient, how that number goes all the way to 1,138. Wow. So that's huge. Treatment can be CPAP, oral appliances, CPAP with oral appliances, skeletal expansion, and surgical procedures. So the guideline to follow, just a second, guys. Sorry. So the guideline that we follow is below 35, oral appliances, skeletal expansion appliances, they all help. If it's 35 to 65, CPAP may be required, along with all of the others. And if it's above 65, everything, because you need to get that patient alive. So people don't understand the importance of snoring here. It's ridiculed in our geographical area. And it's classified based on the volume. If it's heard across buildings and rooms, okay. Even this is snoring. Very light. What is snoring? The tongue going back and hitting the small uvula behind. Tongue going back, the jaw going back and hitting that small uvula. So you need to bring that forward. How much forward? I'll show you. So what is normally done for treatment is the CPAP, which pushes oxygen to hold that tongue forward, or an appliance that will bring the jaw forward so the tongue is forward. There are several appliances, adjustable, Somnomed, TAP, tongue retaining devices. But it's not about the appliance. It's about the bite registration for the appliance. I don't care what appliance you use. It doesn't matter at all. As long as the jaw is kept forward. Support from the maxilla. Hold it forward. At what bite? What we have been taught by several of these sleep appliance companies is 70% maximum protrusion for everyone. How is that even possible? Can everyone have the same bite? Every human being would have a separate muscle physiology. And that's how these appliances come to be known as mad appliances, mandibular advancement devices. All the other sleep physicians are happy how they call it mad. So we need to be very much aware of this. So what we use is kinesiography. So we know at which jaw position the muscles are the most relaxed. You can see position number 3, the muscles are only at 1 microvolt, and that's the position that we're going to record the bite at. It's that precise. So we provide them with a simple appliance, sound sleep, and keep everyone happy. But again, that doesn't take care of the cause of the problem, because more often than not, the cause is a narrow arch. So we need to expand. Nasomaxillary constriction is a very common sign that we see in all these patients. There are several appliances out there. We know all of these. That's been taught about this, quad helix, Crozat. But again, these are all dental. Again, Hyrax has, they're all dental. Which is why we come up with MSc and MAPE. So a lot of orthodontists do MSc and MAPE, great. But you have to use the face board to bring it forward as well. Face mask to bring it forward as well. Which is why I believe in physiological appliances. It may be slow, but it's physiological. It uses the that human beings' muscle forces to help grow. The ALF mainly for kids and the DNA mainly for adults. But both those appliances are heavily regulated. Again, Vivos is a company that makes these DNA appliances that helps in adult expansion no matter what the age. It's it's very expensive. We have worked out a deal. This is what I've been doing throughout my life, trying to get all these companies from the US to understand the socioeconomic conditions in Asia. So we have worked out a deal. They're coming to India with cheaper prices so that a lab in India can make it. But you need to be a provider. So we are having workshops to help you reach that provider status, and you can start helping the patients. The ALF appliance was discovered by Dr. Derek Nordstrom, who has lectured online for one of our ICCMO India conferences. He's known to be as the inventor of the Omega loop. He did not, unfortunately, fortunately, he did not patent it. The ALF is an adaptation of the DNA is an adaptation of the ALF appliance. They call it the mmRNA, which is a modified DNA appliance, which also works as a sleep appliance along with expansion. So it's just out of this world technology. It's amazing. So be it MSc, be it Vivos, is going to expand. You're going to find spacing, which is why orthodontics is very important. CCMD, my favorite subject again. TMD is archaic. Again, because we treat only pain patients, we have been noticing that at least 30 to 40% of our patients come to us with pain because of a malocclusion, but no pain in the TMJ. The TMJ is perfectly fine, even in the CBCT, even on palpation and everything. But they still have a problem because they have a malocclusion. How do we know? Because the other diagnostics is a tick mark. With every change in jaw position, there is a change in the cervical position. And this is the reason why. Because the occlusal plane is in the same line as your C1, C2 plane. And hence the importance. So every time you do a filling and if that goes up, you saw the lady with the postural dystonia, she had mentioned it to her dentist that the filling is causing the problem. But the dentist just couldn't understand the relationship. Why? Because all our lives, we are stuck with what has been taught to us in the final year. Just those 7, 8 subjects about teeth. We forgot what was taught to us in the first year, second year, and third year. We need to relearn. And this is how important our role is. Erect posture. The first and the last point need to be in line, and everything in between follows it. The first, the topmost, superior most is the occlusion, because that controls the TMJ, the glenoid fossa, because that has to be in a straight line with your neck, shoulder, hip, knee, and ankle. And like I showed you, if there's a change here, the whole body goes into a descending situation. The ideal person to help treat this is a chiropractor, but there's a lobby out there that wouldn't let them set foot in India, and they have been ridiculed again, just like dentists. I would relate to the that 2.5 Men, where Alan is a chiropractor, is always ridiculed, and then Hangover, where Stu is always ridiculed as a dentist. Actually, these two are the guys that are helping most of the patients, can help most of the patients, but we need to work together. So Dr. Mariano Rocobado from Chile, I've attended his course as well. He helps the dentists to get that cervical vertebrae in position. Dr. Prabhu Raman would be doing a workshop on this technique during the conference. And that's how we use this in sports dentistry, because the mouth guards that we provide are in that specific position that will help maintain balance. And we use equipment for this as well. You can see the MAT scan. There's a chiropractor who just hired to the bite registration in the same room at the same time. So, in short, think physiologically, help the patients by recognizing not just their dental problems, think muscle, think joints, think teeth. Patient is happy, no more headaches, no more neck aches, no more back aches, better posture. Is it magic? Not at all. It's just common sense. It's just logic. We need to think beyond teeth. Why and how are you sure? Because it's all measured. So when you talk about research and proof, every patient is proof because every step is, proven with data. And it's not just TMD, it's migraines, it's headaches, it's trigeminal neuralgia, it's cervical dystonia. We have beautiful cases. It's all on our website, on YouTube. You can search for them, you can see them. Cervical torticollis, palatal myoclonus. So to understand all of this, as a first step, this would be the ideal place to come and learn, like the logo, the four topics that we concentrate on are TMJ, OSA, CCMD, and posture. It's happening at the Lalit Golf and Spa Resort. Just to understand, make you understand how important this would create, your importance in your area. Like 1.4 billion Indians there, only 10 to 15 practice, believe it or not. Okay, so you could be the first in your area, and that's very important because no one knows about this. None of the ENTs, none of the physiotherapists, none of the pulmonologists, none of the physicians understand any of this. You are the one who's going to help the patient. All these patients are just going around in circles. Patients who come to me know more than the doctors about their problem, the fact. And it's generally treated by, so that's what we've been taught, send it to the MaxFac. So the MaxFac surgeons, they injections and surgery. Yes, you can do it if it goes into ankylosis, but till then, it's always myogenic. So if your diagnostics show that you can treat it, then you should treat it. Avoid surgery. And, there are 40,000 dentists come out every year. They're just looking for jobs. Neuromuscular dentistry provides you that stepping stone to become better at what you do, adds to your revenue, no doubt about it. I'm telling you, if you start looking at these things, small things, everything is going to get better. So attending the conference would be the first step in the advancement of your career and social life. This is the conference that we're talking about. You can see all those speakers. There are like 35 speakers there from all over the world. All over the world. It has been a tremendous, tough task to get all of this organized, to get all these speakers in place. Why it's a little over budget, but yes, it would be worth the money. Now, when you talk about money, I know it shows $1,000, $900, but we have special offers for Asian doctors, for Indian doctors. So please contact us. Promo codes will be provided. Dr. Elvia, Dr. Nupur can help you with all of that. These are the two highlight workshops. Vivos, like I said, is the DNA appliance. Dr. Tamari herself, she has taken over with the research part of it. She's going to come and take into an entire workshop on how to become a Vivos integrated provider, Asia, so VIPA. SDI Matrix is an axiometry company, which is, jumping leaps and bounds with technology, amazing technology. It integrates face scan with just a simple mobile. You don't need to buy that entire unit. It's just a simple mobile. Take photographs and it integrates face scan, the CBCT, the intraoral scans of the jaw, the model scan. It integrates everything, and you can see in live how the condyle is moving, how the jaw is moving with every positional change. It's amazing technology. And the king of all of this is Dr. Javier. He himself is coming to India to do an entire day workshop, 8 hours of workshop. We're going to do 2 live cases there. So take advantage. And then we have the god of occlusion, with the disclusion time reduction protocol. Dr. Rob Kirstein is going to be there. He's going to be spending an entire day showing you how this is done. And then there is our very own Dr. Prabhu. He just an amazing guy. I've spent an entire week in his office. How he integrates all of the cervical physiology, the muscle physiology, the posture into shooting that bite A to Z, step by step with the Myotronics equipment. He's going to help you learn all of that during his workshop. And then we have Dr. Girish, who's going to help you with a half-day workshop, how to become an ALF provider. It looks very simple, but it's very difficult to manipulate. So to maneuver. So you need to understand how to do that. This would be an intro session. So got to be there, and it's sponsored by the Right by Dudent Neuromuscular Orthodontic Lab, which is the only lab in the whole of Asia that makes neuromuscular sciences. So when I came to India after learning all of this, I found it very difficult to find a lab who understands what it is that I'm saying, how to make that bite, how to make that orthotic. I sent it to all these big name labs. I'm talking about 2002, 2003. They don't understand this. They just break that bite that been painstakingly taken after 2.5 years, 2 hours of my time, and they put back in centric. So I had to train those guys. They were sent to the US, they were trained, and now this lab is the only one that makes these appliances. So be there for the ALF workshop. So to conclude, de-learn like how we have to deprogram the muscles, relearn like how we have to reprogram the muscles, and keep learning. Always keep learning. This is what I do. I'm always learning. We all are, in ICCMO India at least. And you cannot do everything by yourself. You need a team. You need a chiropractor. You need an ENT. You need a neurologist. You need a physiotherapist. You need a psychologist. So why a psychologist? Because when we call it biopsychosocial, right? What we've been taught is 95% of all EMD is biopsychosocial. No, wrong. In my experience, it's the exact opposite. And 5% everything else. I've seen 95% is myogenous. And 5%, because the patient was not able to take care of it, they become psychosocial. And then they are on psychiatric drugs. So we help these patients with the pain. It's so difficult to wean them off the psychiatric medicines. So what started out in 2000 with dentistry, went on to occlusion, and then sleep apnea, posturology, and now we are looking at the entire well-being of the patient. Take home point, we are not just tooth doctors. Look beyond that. We are oral physicians. I love that term. Dhanyavad, gracias, placebo, obrigado, from wherever in the world you are. For information, you can come to tmjindia.com. You can the website for the conference is ICCMO 2023 India.com. Again, Dr. Elvi and Dr.